everyone, and thanks for joining today's webinar focusing on when implants fail, how, why, and what to do. My name is Adam, Content Marketing Specialist with Henry Schein, and I'll be your moderator. If you have questions, please type them into the Q&A section of your control panel, and we will cover as many as we can at the end of the webinar. Please make sure that your volume is up and any large applications are closed on your computer or mobile device to ensure a smooth connection. This webinar is presented by Henry Schein Dental, and no CE credits are being offered for viewing this presentation. Our speaker today is Dr. David Wong. Dr. Wong is a board-certified periodontist and is a diplomat of the American Board of Periodontology, as well as a fellow in the International Congress of Oral Implantologists. Thank you for the time, Dr. Wong. Over to you.
Thanks so much, Adam. I appreciate everybody for being here at lunchtime, Central Time anyway. Anyway, I'm coming to you guys from Tulsa, Oklahoma. As many of you know, I'm a periodontist here in private practice, and today we're talking about when implants fail, how, why, and what to do. So I've only got an hour with you all, so we're going to blast through a ton of material covering a wide array of topics as far as failed implants. So let's go ahead and get started. A lot of you guys know I'm easiest to get contacted through with Instagram. I've got two different accounts. There's the david.wong.dds for all of you socialites out there, and then there's a Plaque China for all of you all who want more clinical content and that type of thing. So anyway, if you guys have any questions after this, because it is a short presentation, just feel free to message me. I'm pretty good about getting back to you, so just shoot me a message and we'll talk. Anyway, what today is about is failed implants in all different varieties. So we're going to talk about, poor implant placement. We're going to talk about, surgical failures. We're going to talk about Peri-Implantitis. We're going to talk about retained cement. We're going to talk about how to utilize a Cbct. We're going to talk about receding gum tissue on implants. So we're going to talk about a lot of different things here in the next 58 minutes. So the goals for today, I'm going to start off talking about a few little implant complications that are pretty common, non-surgical related type things. Then we're going to talk about implant fixture failures. Then we're going to talk about failures in implant aesthetics. And then we'll move on to Peri-Implantitis, as well as what to do as far as utilizing bare minimum technology to maximize your implant success. So real quick, what exactly is a failure? A failure is quite simply not meeting a desired or intended result. So with that in mind, let's talk about non-surgical related implant complications / failures first. First of all, probably the most common thing out there, if you're doing any dental implants, fortunately, we don't get too many failures with the success rates of implants, but we do get a lot of these loose abutment screws. Depending on the literature that you read, this can occur up to 12% of the time, depending on the implant design and that type of thing. But there's a couple recommendations that I'm really thrilled about that we're doing lately, which is all, mostly screw retained restorations. So whenever you have, let me back up here. We're looking at tooth number 11, which is a cement retained implant, the supported crown. So whenever you have a lingual access, it's really simple for us to retrieve a loose abutment screw. And we quite simply just treat it like you're doing a root canal on the tooth. You go in through the cingulum, you drill through the crown, and you find the abutment screw. One quick tip here, usually when you're drilling through the porcelain of the tooth, you're going to use a diamond burr. And then once you get into the metal coping, that's usually when I start switching over to more of a carbide. The reason that is with diamonds, you tend to chip the porcelain a lot less. The worst thing you can do is, of course, is drill through somebody's crown and you break off the whole incisal edge or something. So for drilling through porcelain, I recommend a diamond. Once you get to the coping, you can maybe stick with your diamond, but that's usually about the time that I'll switch over to a carbide. As far as equipment goes, you want to make sure that you have a long enough driver. A lot of times when you're drilling through a crown, most people don't have a long enough driver, so make sure that you have a long enough driver. You should always have one handy just in case. Anyway, after you access the abutment screw, torque it down, put a cotton pellet or plumber's tape over the top, and then just fill it back up with composite, and voila, you're done. Once again, this can be kind of annoying because it can happen, up to 12% of the time with some of the older implant systems. It doesn't happen as much nowadays, but just be aware that this is how you would fix that. What happens if you don't fix it? A lot of times patients don't understand that, or they don't realize that they have a loose abutment screw, and it's amazing what they don't know or what they're unaware of. So whenever you have a loose abutment screw, what you'll notice on a radiograph is that you'll have a gap between the abutment and the implant body. And it's important that we fix these things. And that's why perio maintenance is really important, not only to clean the implant, but also to evaluate the occlusion, to take a radiograph and evaluate the bone levels. So here's just a real quick example. If you look at the upper right side, where you have a loose abutment screw, you can see that the crown is separated from the implant body. What happens is if a patient isn't aware of it, doesn't tell you about it, or we glance over it and don't realize it, what ends up happening, and I'm going to show you here, the bone at first will be unaffected, but just like an open margin on a restoration, it becomes a plaque trap and you have a bacterial pump. So the next radiograph, you're going to see, the 50% bone loss or more around the implant. Now, of course, we tighten it down, but it's too late. The bone is gone from the implant. So be sure that we check those implants at the maintenance visits. Retrieving a broken abutment screw. So now what we're doing is we're going from little bitty things that are kind of a nuisance to, okay, now things are really starting to get on my nerves. So what do you do about a broken abutment screw? So in a situation like this, what you're going to see is we had a healing abutment break off, and the screw is stuck inside the implant. The reason the tissue appears that way is we use a laser to expose the implant platform. So now we're looking at the broken screw. So how do you retrieve that? And what you do basically, if I can get my cursor here, what we basically do is we'll just grab a pigtail explorer or the number 23 cowhorn explorer. And fortunately, what usually happens with broken screws is that they loosen up and then they break. That's typically what happens. And that's why it's allowed to break, is because the screw's loose. So what you end up doing is just grabbing a pigtail explorer, and you just, usually when it breaks, there's always going to be some level of unevenness there at the top of the screw, as you can see here. And you're just going to rotate, with your explorer, just counterclockwise along the edges of the inside walls of the implant. And I would say this works well over 90% of the time. It's been a long time since it hasn't worked. At any rate, the next trick I'll show you when this doesn't work. There are other things that we can utilize as well. But here's just a quick, easy tip for you all on how to retrieve a broken or a broken abutment screw. The next cases that we're going to talk about is what happens when you actually have a broken abutment, as well as a broken abutment screw. So things can go from a little annoying to bad to worse. And we're going to walk through all those scenarios really quickly within the next few minutes. So here we've got the screw. It's loose now. At this point, you can just reach in here with some cotton pliers or something and just remove it from the implant body and then replace it. So that's how you retrieve a loose abutment screw. So now we've gone from loose screw to broken screw. Now we're going to go to broken abutment. So these are all, for me, some people call them complications. I call them failures just because from a patient's perspective, it's a failure. They paid their money, they've done the treatment. They don't really want to come back to your office for more surgery or more procedures. So from this perspective, it is an undesirable result. So let me walk you flash forward here to this other case. This case is one of my cases that I used to talk about as far as like proper management of sinuses and ridges. And in a situation like this, what we did was, for this patient, we did a sinus graft and we placed 2 implants. So this is after the sinus graft was completed. And then we went ahead and placed 2 implants for a 3-unit bridge. They're good size implants and the restorations look great. The problem is after less than 2 years, the gentleman noticed that his bridge was loose. And the most common thing that happens when a bridge is loose is just the abutment screws are loose. So just like I've shown you earlier, we accessed the bridge, the screws through the bridge, tried to tighten them, and they, the driver would engage the head and it just spun and spun and spun and spun. Okay, so nothing ever happened. It just kept spinning to eternity. So that's when I realized that it wasn't the screw that was loose, it's actually the screw and the abutments were broken. So what ended up happening is the next time I saw the patient, he came in with the bridge in his hand. And that's a miserable feeling. If you've ever been the surgeon who's gone through the sinus grafts and the implants, and your restorative doctor has already done a good job with the bridge. So this is what it looked like coming out that he brought when he brought the bridge back to me. And you can see that we have broken abutment screws as well as the broken abutments. So what do you do in a situation like that? First thing I always do is just think, were the implants placed improperly? And when you look at it, when you look at the access holes, the implants are placed right where I would have wanted them to be. So this is just a matter of, not taking into account the patient's force factors, and he just simply fractured the abutments and the abutment screws. So this is what it looks like clinically. You can see what we're trying to deal with. So when you're dealing with fractured components that are flush with the implant body, what do you do? You're like, oh my God, how do I get these out? Fortunately, most companies do make a implant component retrieval kit. So in this situation, we have a forked ended burr here that we can put in a handpiece. And what we do, the first thing that you've got to do is get the abutment screws out, okay? That's objective number 1. So we put this forked instrument over the top of the broken abutment screws like you can see here. And then we just slowly turn it counterclockwise. And fortunately, the screws do come out, because once again, what typically happens is that the screws get loose and then they break. That's usually what happens. So now that the abutment screws are out, you can see the broken abutments. What do you do now? So, and this is a bigger challenge, because what's happening here with a lot of our modern day implant systems that rely on a more taper type connection, you're basically, we're trying, this abutment is wedged into the body. So how do we retrieve that? So now we have another instrument. And this has another instrument that goes into either a handpiece or a torque wrench. And you'll notice that it's got a few little threads on it. So what we do is we just thread it gently into the remaining fractured abutment piece. And then you simply just pull, just yank it out, wiggle it and pull it out. And that's what we did here. Fortunately, or unfortunately for me, I only bought one of each. So I had to use both of them for both of these implants. So I was then out. So this was one of those situations where if this didn't work, I definitely would have been up the creek a little bit. But fortunately, both of the broken abutment components came out, and that's what those look like. And now we're clean. The insides of the implants are undamaged. So now we can simply just put healing caps back on and basically just start over. Now we go from bad to worse. Now what do you do about a fractured implant? So in a situation like this, this is a classic situation where we have single tooth, number 30, implants, been restored. Things are going well until the patient, comes in with some soreness, some bleeding, some pus coming out of the area, and you're thinking, what is going on? Of course, then you take a radiograph and you'll notice on the distal end of that implant body, you'll see a fracture. So now what do you do? We have a gigantic, 5 by 10.5. This is a BioHorizons, internal hex implant. And here you go. It's flapped open and you can see the fracture. So, but the implant's integrated. So how do you get this thing out? You know, there are little reverse torque kits that work. That wasn't available at this time because this was about 12 years ago, I believe. So in a situation like this, we have to get a trephine burr, and we have to, you know, cut the thing out. And when you cut it out, you can see how well integrated the implant is to the surrounding bone. So what ends up happening is when you replace it with an implant and put the crown on, now you're compromised as far as the quality and the quantity of the bone that you're dealing with. Of course, now you have force factors that you have to deal with. So you're definitely in a compromised situation. The good news is there's easier ways to do this now. And this is the final restoration of the second time around. But there is a better way. So what the better way is, so let's say we've got another situation here. You have implant number 12. That's it's an old press fit cylinder implant. It's broken in the apical third of the implant. So now what do you do? And it's really jammed up in there. So what we do now is, instead of trephining it out, we do have piezo surgery units that work really, really well. And I'll show you that real quick. So here's a piezo surgery tip that we're inserting around the broken implant body. And you can see all the facial bone destruction that has occurred with that fractured body, by the way. That was not done by me. That's just the way the case presented. So we have a large dehiscence, and apical to the dehiscence is where your broken implant body is. So here we're using our piezo surgery unit to make a very, very fine incision around the implant body. And you'll see here that we can get the remaining tip of that implant out just fine. What that allows us to do is not damage the bone. We don't overheat the bone. It gives us a better opportunity to regenerate that site like we're doing here. We place a membrane, we can suture. We can get our bone prepared so that the patient can have another implant. That's basically what we're aiming to do. So technology has really come a long way. And once again, if you don't have a piezo surgery unit, the reverse torque units from a variety of companies work very well also. So here we are, the older patient. She just wanted another cement retained crown, which is fine. Cement retained crowns are fine, except you got to remember to remove the cement. So that's how we would retrieve and restore a fractured implant body. The take-home message for these first cases is that you want to account for patient force factors. All too often, I'll see people that treatment plan only to the quantity of the bone that the patient has. So, for example, they might measure on a CAT scan or whatever that the patient can have XYZ size implant. That's what they place. The problem is that a large male might have different force factors than an edentulous female. So we have different patients that we have to account for. So we need to account for patient force factors and not just buy into the idea that we just place the implant into whatever the bone will allow. Consider screw retained restorations whenever possible. It just makes your life a lot easier to retrieve things like broken components. Torque abutments properly. You want to report any screw loosening and component fractures immediately, because as soon as things get loose, that's when a patient can bite down on the implant crown and break it. That's when it's most susceptible, is when things are loose. For adjacent implants, there's a lot of debate here, but if we're really considering a patient with high force factors where abutment screw loosening is more common, you might want to consider splinting the implants together. Okay, that way things get loose a lot less. The downside, of course, is the patient can't floss, and they may not want to do that. So it's just something that you should bring up in conversation with your patient. Finally, monitor the occlusion. Check the occlusion. Put them in a night guard or an occlusal splint as necessary. Okay. So peri-implantitis. How do we deal with peri-implantitis? So here is a case that I did probably 7 or 8 years ago as well. We did implants for number 8 and number 9. Things came out beautifully. A couple years later, the patient comes back, man, my gum tissue is really, really tender and it bleeds when I brush. And for me, I'm like, I don't know why that would be. It's 2 front teeth, all your other teeth, are you do have some issues, but not the front teeth. What's going on? Those are brand new teeth. So when you just gently peel back the gum tissue, or actually, let's look at the radiograph. When you look at the radiograph, you'll notice that we have crystal bone loss around the implant around number 8. And then clinically, if you recall, it's very, very inflamed, edematous, a lot of red, angry-looking tissue. So what's going on here? It doesn't take a genius to do this, but you just gently peel back the gum tissue, and you'll notice that there's just a big wad of cement in that area. So what we need to talk about next is how do we address the pocketing and the inflammation and the bone loss around these implants. So typically, when it comes to implants, we treat them pretty much the same as we would a tooth. If you would save a tooth, you would save the implant. That's basically it. If you would remove a tooth, you would remove the implant. So very similar thought process. So if we look at a case like this, tooth number 30, where we have severe bone loss at the crest area, it's an older type implant. It's once again a press fit cylinder implant. I'm kind of showing my age a little bit here, but it's tooth number 30, 2 vertical defects that circumscribe the implant. So what do you do in a situation like this? You treat it just like you would a tooth. So if you were going to bone graft around a tooth, you do it the same way. You'll notice that there's calculus and debris on the implant surface because it's an HA coated implant. So what do? What I like to do is I will just smooth it all out either with mechanical or rotary instrumentation. And then the next thing that we do is we'll actually put a tetracycline slurry on the implant surface. So what a tetracycline slurry is you basically go to the pharmacy, you get a capsule of tetracycline, you empty it into some sterile water, and you mix it all up. And it's going to make a slurry. Okay, it's going to make a little bit of a liquid type paste. And then all you do is you just put your cotton pellets in it, and you burnish the implant surface for about 4 minutes, and it puts a nice little etch on it because it's got a pH of about 1. That's going to clean your implant surface, just like if you were scaling or replane a tooth. So at this point, the next step is going to be to put your bone graft material of choice. That's a whole nother type of lecture. But anyway, we're putting a bone allograft around the implant surface. I'm sorry, this is a xenograft. But anyway, you're putting in some freeze-dried bone around the implant surface. And then you close it up. And what happens is a year later, take another radiograph, and you can see that we've got some bone fill up around towards the crest of the implant, which is a pretty good result. Does this happen all the time? Of course not. Does it happen predictably? Depends on who you ask. But it's definitely worth a try because you have to consider the alternative, which would be, like I showed you earlier, which would be to remove the implant. Sometimes that can be rather destructive. And this is somewhat uninvasive. So definitely something to try as long as the patient is asymptomatic and you can control the inflammation. It's definitely worth a try. So here's another case. Here we have an implant bridge from number 3 to 5. Number 5, as you can see here, has severe bone loss on the mesial aspect. And the decision, this is an 84-year-old man. He doesn't want to start over. So what we're trying to do here is try to treat the infected tooth, which is actually tooth number 6, while saving the implant of in the number 5 position. So here's another radiograph of that. So what do we do here? So here's number 6. It's severely periodontally involved. So what we do is we're going to peel back a flap. You're going to see the exposed implant surface of number 5, but we're after number 6. So we actually remove that tooth, and we're very, very careful to leave the facial, what was left of the facial plate. So that took a little bit longer than I'd like, but it got done. I'm going to use this case to highlight some principles of bone grafting real quick. So the first principle of bone grafting is that you have to have a clean surface. That was the reason for the tetracycline slurry that I talked about earlier. You want to buff and shine that implant put a nice little frosty surface on it with the tetracycline. You also want to degranulate the socket real well. So this is tooth number 6. And after that, the other principles of bone grafting that we're going to abide by is we're going to add bone into the defect as well as around the defect. That's what we can call barrier by bulk. Once again, that's another lecture, but this kind of gets you an idea of how we manage these cases. So we're placing our bone graft material into the defect as well as around the defect, and then we'll cover it up, which is our last principle here, which is making sure that the graft is stable and properly sutured. Okay. Here we've used a resorbable collagen membrane. It's a Memlock by BioHorizons as well. And then here, 6 months later, we let that heal up. We can take a new CAT scan, and you're going to notice that we got some bone back around the implant number 5. This is our implant site for number 6. And implants placed, and you can see that we've got great bone now on the mesial aspect of number 5. And this is actually long-term at this point. I'm going to show you this. So with implants placed, we went ahead and just provisionalized this gentleman until things were stable. So he just opted for the stock abutment, just went as low shelf as he could, which is fine. You know, I get it whenever, sometimes elderly people don't really want to invest a whole lot. So here we've got the restoration in place. We do have some abutment exposure on implant number 5. He does not care, but at any rate, the bone around number 5 at 2 years now, by the way, looks really good. Now, when we're treating peri-implantitis around the front teeth in the aesthetic zone, different story, okay? So here we have tooth number 10, implant number 10. You can see from the facial, things look pretty good. The only indication that there's a problem clinically is that you'll notice some slight edema, a little bit of erythema around the facial gingival margin. Very smooth surface, loss of stippling. So that's the only clinical sign. So the patient's really not happy about having crestal bone loss around this implant. And this could be caused by cement. This can be caused, this may have even happened after the implant was placed. Maybe there was, too much torque. Maybe there was too much heat. There's a lot of different reasons. At any rate, when you look at this clinically versus radiographically, the two don't match up. You can see quite a bit of bone loss radiographically. The biggest thing I can tell you to avoid in a situation like this is at all costs, try to avoid reflecting a flap, because when you have this much bone loss around an anterior implant, once you reflect the flap, it's going to cause a lot of recession, a lot of big time loss of papilla, especially when the papilla are already kind of small. Okay, you can already see some small black triangles there. So what do you do then? So this is what we would call peri-implant mucositis, which is gingivitis around an implant. Peri-implantitis is what is bone loss around the implant. So we actually have peri-implantitis going on with this implant. So in situations like this, you want to try to tunnel underneath the flap and around the implant. And also, I utilize a lingual approach. I'm going to show you why here in a second. So here's our xenograft. By the way, for implants, I typically utilize a graft that stays around a little bit longer, like a xenograft, or mineralized cortical bone, human mineralized cortical bone. So we're going through the tunnel flap through the lingual, and the reason we're doing that is we're trying to avoid reflecting any tissue on the facial aspect. And in this way, we can actually achieve a pretty decent result as far as getting the implant reasonably clean, getting the graft stable because there's no flap to really manage. And then, of course, suturing is really easy. Here's our final result here. This is at about a year. Once again, when we look at the clinical result, things look pretty good. We got the stippling back. There's no clinical inflammation anymore. Radiographically, we got good bone fill. But if you look at the papilla, I'm going to show you this. This is the before, and you can see that shiny, erythematous, edematous facial marginal gingiva. Now it's better. The facial gingiva does not change a whole lot, but look what happens interproximally, where we added the bone. just by manipulating the papillae, even though we didn't reflect them, we tunneled, you're still going to lose a little bit. So that's why I say if you could only imagine what would happen if you reflected a flap, things would be a whole lot worse. So I'm going to leave you with this one slide here. The big difference between gingivitis and peri-implant mucositis, which is just gingivitis around an implant. Look at this. So the chances of gingivitis around a tooth becoming periodontitis is 30%. But the chances of mucositis around an implant becoming peri-implantitis is 60%. So you're twice as susceptible for the disease to progress around an implant than you are around a natural tooth. So the key point here is to treat inflammation around implants early. So as soon as you see something, do something, okay? Don't continue to watch things, especially if they're bleeding, if pockets, keep getting deeper and you see continued bone loss around the implant. Next thing we're going to talk about is implant aesthetics, failures of implant aesthetics. This is a book that I contributed the soft tissue chapter on for the editor, Dr. Dwayne Caratu. He's the chair of Perio, grad Perio at the University of Illinois in Chicago. Highly recommend this book, not because I wrote a chapter in it, but because it's very easy to read and it's very comprehensive. You'll notice here too, a lot of the same names in implant dentistry that we follow and read a lot of their literature. So the purpose of dental implants is that we can't tell that they're dental implants, right? That's why patients come to us. They want teeth. They don't really come to us asking for implants. They come to us asking for teeth. So we want to get to a result where we can look at a photo like this and not be able to tell that the implants are number 6, 8, 9, and 11, right? We want to be able to tell that it's not, the implant's not tooth number 8. We don't want situations like this, right? These are what we would call an implant failure, I believe, right? This is definitely an undesired result. So we don't want recession around our implants like this or this, right? This is even worse. So these are all cases what we need to learn how to avoid them more than anything, how to treat them. There are people out there for that, but let's try to avoid them. So how do we treat them first? Okay, so whenever we have a situation like this, we have a failure around the implants from a cosmetic perspective, from a perio perspective, it's a failure. It's gingival recession around implants number 24, 25. You don't see any keratinized gingiva. There's no attached gingiva. You have a series of Freenham pulls. And what do you do about it, right? The implants are too close together. They're too big, whatever, right? There's maybe the patient brushes their teeth too hard. What do you do about it? So the key thing here is what we typically consider is a free gingival graft versus a connective tissue graft. So we're trying to utilize some type of soft tissue graft to address the mucogingival deficiencies there. By doing so, our hope is that we're going to allow the patient, give the patient a more cleansable environment so that they can take care of it. We can also stop the bone loss around the implant, stop the recession. That's the whole goal of treatment at this point. Whether or not the patient's going to recover cosmetically, we'll figure that out later, but right now we just got to get healthy again, okay? So what's the difference between a connective tissue graft, which is on your left, versus a free gingival graft, which is on your right? So goal of management, once again, we're going to try to start at the base of the pyramid. We're focusing on the health of the patient. So in a situation like this, I chose a free gingival graft because just like the case before with the Peri-Implantitis, the less manipulation I can do around the marginal tissue, the better I am, because we don't risk increasing the sizes of the black triangles. We don't risk increasing more recession. So I chose a free gingival graft in this situation. You get a ton of keratinized and attached gingiva. It addresses the Freenham pool a lot better than a connective tissue graft would. So when you look at this thing at 2 weeks, you'll notice that the tissue is very, very thick and robust, very sturdy tissue. But not only that, you're going to notice a phenomenon that we see in perio a lot, which is called creeping attachment. And what creeping attachment is, this is from a paper from Mate, a very classic paper in J. Perio in 1976. And what happens here is when you put a free gingival graft around a recession defect, even though you don't cover the recession defect, over time with good oral hygiene, that tissue creeps up, creeps up the root surface. Which is a nice phenomenon. It doesn't happen all the time, but it does happen quite a bit where we're not surprised anymore. We also know that it's not studied very much around implants. Matter of fact, this is the only paper that I could see, which was in IJPRD with 2 case reports back in, I believe this is just 2018, right? So what we're noticing here is that when we place a free gingival graft around recession on implants, we do see some creeping attachment a lot of times. As for me personally, we see it quite a bit as well. Here's an implant number 23. We have quite a bit of recession on it that's noticeable. We place a free gingival graft, and here's what you can see at 1 year versus 2 year, and then at her 3 years, she was out of town, so she sent me a bathroom selfie. But you can see even at 3 years, the tissue is nice and stable, and we even got some creeping attachment up on the abutment surface there. So if you're interested in free gingival grafts, follow my Instagram or whatever social media. There's lots of people who do a lot of free gingival grafts, but it's definitely a procedure that was out of vogue probably about a decade or 2 ago, and now it's coming back, especially since we're seeing more of these types of problems around dental implants. So in a case like this, in the aesthetic zone, we have tooth number 9, no keratinized or attached gingiva present. It shows when she smiles. She is not interested in remaking the crown at this point. She just wants her gum tissue to be healthy again. So we have thin facial tissue, have a frenum pulls kind of in the way as well, right between number 8 and 9. Plaque control is not very good just because it hurts when she brushes. The implant placement's just okay. It's a little bit to the facial, but once again, this implant was placed over 20 years ago. So what do you do, right? Sometimes for fun, just for kicks and giggles, I'll go to an Instagram and I'll create a poll. And what was interesting is about 52% of the people wanted to remove this implant. Only 48% wanted to fix it. What was also interesting is that of the people who wanted to fix it, about 3/4 of the people would choose a connective tissue graft over a free gingival graft. I thought that was kind of interesting, only because not only am I in the half of the people that wanted to fix it, I'm also in the 25% of the people who chose a free gingival graft. So here we are preparing the free gingival graft bed, placing the small graft over the facial tissue, over the facial defect. And then 2 weeks later, you're going to notice, pretty good healing so far. And at 3 months, things are looking pretty good. Once again, this is a stock titanium abutment. The crown could stand to be remade. But at 1 year, things are not too bad. Certainly, they're a whole lot more healthy than when we started. So in that regard, the main objective of creating a healthy environment has definitely been addressed. And cosmetically, I think we can all agree that it does look better than it did before. Another scenario like this, we have tooth number 8. You can see that we have a zirconium abutment, which is still equally ugly whenever you have that much of it exposed. So what do you do in a situation like this? This is what it looks like radiographically. We have bone pretty much all the way up to the first thread. Not a whole lot of bone loss, but clinically you can definitely see that that's a problem, right? From a patient perspective, that's a failure. In the implant literature, we would consider this a success, but the patient's right here, right? It looks horrible. So what do you do? Once again, you could remake the abutment, redo the abutment, redo the crown, but she's already done that twice. She didn't want to do it a third time, so she's looking for a surgical solution. What I see clinically is that we do have some recession with the abutment exposed. We have good, adequate keratinized and attached gingiva. We don't have a high frenum pull like we did on the last case. And there is a small facial concavity if you look really closely. So what do we do? From a surgical perspective, what do you do? So once again, going back to the polls here, what's interesting about what we see with our eyes is that when the tissue looks healthy, that's when we want to fix it. When it looks unhealthy, that's when we want to cut things out. I don't think cutting out this implant is going to be a very good option because, from a cosmetic perspective, which is the failure in this case, you're going to end up a lot worse taking that implant out. So not only are we wanting to fix it now because the surrounding tissue looks better, but now we're also leaning more towards, we're still looking at, more people wanting a connective tissue graft versus a free gingival graft. And I agree, right? So this is how we harvest a connective tissue graft. This is me harvesting it from the left side of her palate. And we're using connective tissue graft in this situation because we're trying to get the abutment actually covered a little bit more predictably. And also we have good surrounding tissue, so there's no need to thicken the keratinized or attached gingiva. There's no need to address a frenum attachment or anything like that. So that's why I chose a connective tissue graft in this situation. Connective tissue grafts also have a better color match overall. And generally they have a high success rate because we're not around implants, especially because it's covered, with the patient's tissue versus just left hanging like a free gingival graft. So that's how we harvest our connective tissue graft. And then going back to the rules of grafting around implants is the same as teeth. You would scale and root plane a tooth before you graft it. You're going to do the same thing with an abutment. It sounds a little bit weird, but you're not going to do it with a scaler. You're just going to do it with a burr. So here's a burr. I'm going to smooth that abutment down, make a nice flat surface. It's easier to graft to a flat or a concave surface versus a big, convex surface. So here, the flat design, we just decided to tunnel it because once again, we try not to reflect the papilla. That would be a bad thing. Tunnel flap design, I also call it the no-hole surgical technique just because it's kind of a play on the pinhole technique. But anyway, using a no-hole technique, we place the connective tissue graft through the sulcus and over the exposed abutment. Here we are at 3 weeks. Sutures have been removed. We got really good coverage of that abutment. Here we are at a year. Once again, here's 6 months, and then here's a year. So things are looking pretty good when we do things with the connective tissue graft around this recession defect on an implant. So I've got 18 minutes left with you. So how to minimize and avoid aesthetic failure. So in a situation like this where you have tooth number 9 that needs to come out, we have to think, we have to begin with the end in mind. How are we going to replace this tooth successfully? Same thing here, tooth number 8, it's got to come out, it's failed. How are we going to replace these central incisors without successfully and reaching our goals for the patient aesthetically, but reaching our goals as clinicians as far as the bone and healthy soft tissue? So we're faced with a lot of different questions. So how do we extract the tooth? Do we place an implant immediately or not? What implant design are we considering? Where does the implant even go? Do we graft this gap? Do we use a membrane? What type of graft do we use? So we have a lot of questions that we need to ask ourselves. Do we provisionalize it or not? Do we add a gum graft or not? So one question that we have to ask ourselves is, if we're going to take the risk of placing an immediate implant, does placing an immediate implant actually preserve the dimensions of the socket? Where should the implant be placed? Should the gap be grafted? And then should we immediately provisionalize the implant, or should we just place a healing abutment? So these are questions that we need to ask ourselves. The first question, though, the most important question, is going to be, how thick are the facial plates around the teeth? And I say it's the most important question because it's the most important question for most clinicians that are considering immediate implants. We generally want to have a facial plate, right? So when you take out a tooth, how thick is that facial plate? Now, when we look at this classic study here, it's often quoted, and maybe it's not classic, but it's often quoted. When we look at the thickness of facial plates on front teeth, about 87% of facial plates are 1 millimeter thick or less. Okay, that's not good. Okay, because what that means is what happens after sockets heal, that facial plate's going to want to resorb, right? So that's why we have to consider things like socket grafting. And we have to consider, how we're going to manage that with our implant. It affects where we place the implant. So when we're talking about immediate implants for aesthetic success, there's 3 categories of sockets that I like from Dr. Dennis Tarnow. Type 1 is where you have bone present and good soft tissue present. Type 2 is the soft tissue looks good, but the buccal plate is not there. Type 3 is there's no soft tissue and there's no buccal plate. Now, type 1 and type 3 are easy to diagnose and treat. But type 1, you're a go for an immediate implant. Type 3, you're a no-go. Type 2 is where we get into trouble because the gums look good, but the bone doesn't. So how do we determine all this? So everything starts with a good diagnosis and a good plan. So for that, I don't think you can accomplish anything worthwhile in the implant industry nowadays without a CAT scan to at least drive your initial thought process. So grab a CAT scan, look at that facial plate. Here's a type 1. The gum tissue looks good. We have a facial plate. That's a type 1. Type 2, gum tissue looks good. But if you look at the CAT scan, it's terrible, right? There's no bone. Type 3 is easy. Have a ton of recession. The tooth is exfoliating itself practically. And, you know, radiographically, it's going to look terrible. So you have no bone and no gum tissue. That's a type 3. So how much bone is lost after an extraction? So if you take out a tooth and just let it heal, what happens? So we know when you do that you're going to lose a ton of buccal lingual bone. In this chart, I've done a few, just a few classic papers here. You're going to lose between 2.5 and almost 6 millimeters of buccal lingual bone width. That's not good, right? And these numbers are higher because in situations like this, flaps were reflected to take out the teeth. When you reflect a flap to take out a tooth, you're going to lose more bone. So if we look at Dennis Tarnow's study here, what was kind of nice about this setup is we compared four different modalities. Taking out the tooth and placing an immediate implant in all 4 scenarios, okay? The difference was the 2 cases on your left side, no bone graft was placed. The 2 cases on your right side, the bone graft was placed. As we go from left to right, we either started with just a traditional healing cap. We have a provisional for the group number 2. Group number 3 got a bone graft plus a wide healing cap, and group number 4 got a bone graft plus a provisional. And what you're going to notice, I'm going to summarize this because I don't have a whole lot of time. When we look at this, when you take out a tooth, put an implant in, add a bone graft, after that, you can either do a wide healing cap or a provisional restoration, and you lose the least bone that way. When you don't put a bone graft in there and only put a straight healing abutment or even a provisional, that's when you lose more bone. So it's important to graft at the time of your implant placement. Patients with gingival recession. So if you take out a tooth and the tooth already has recession, keep in mind there's an underlying dehiscence there. It's an average of about 5.5 millimeters. So consider that whenever you're talking to your patient about an immediate implant. Sometimes it's probably not that great of an idea. Looking at Dr. Lyndon Cooper's paper, there are 4 factors affecting implant aesthetics: existing gingival levels, implant depth, response of the tissues to implant procedures, which is what causes a lot of your crystal bone loss sometimes, is how the patient responds to these procedures, and then management of the tissue with the abutment and the crown. So we're going to just touch on a few of these concepts really quickly. Here's that tooth number 9 that I showed you earlier. We're going to remove number 9. But before we do any of that, we have to do a CAT scan to look to see if there's a facial plate. There is a facial plate, so I'm going to proceed with our immediate implant placement. So rather than fabricate a provisional from scratch, I went ahead and used his old crown. So the tooth is out, implant is going to go in. Now, where does the implant go? Let's answer that question. For an immediate implant, we're going to follow the 3-2 rule. The 3-2 rule means the implant is placed 3 millimeters apical to the free gingival margins of the adjacent teeth. It's going to be placed 2 millimeters lingual to the facial plate. So that's 3-2 rule. So this is the provisional restoration, which is just his old crown. Just for kicks and giggles, we went ahead and added a soft tissue allograft, added just a little piece of alloderm here. And then this is what we're going to get as our final result, final healing with the provisional in place. Okay, so this is at time of placement, and then the patient got busy and didn't come back for his final restoration for a while. Here's the 1 year, 3 year. Everything's looking very good from a bone perspective. Remove the provisional, everything's looking pretty good. Nice soft tissue, and then we were finally able to finalize his restoration here. So technology and maximizing success. We're going to end up just a tad early so we can do some Q&A. So when we are presented with trauma cases like this is where we got to utilize our technology. So this is a dear friend of mine's mother. She got kicked in the face by a horse, and literally, not even making that up, got a horse kicked her in the face and knocked out teeth number 7 through 10, destroyed the facial plate, no bone, and the tissue never did heal because she had some bony sequestrum. In other words, some dead bone underneath the tissue. So this picture right here, you're looking at her almost 2 months after she had these teeth kicked out. So what's going on here? So in a situation like this, we have to take into account all the principles that we've talked about today. We need better tissue, right? So what's the best way to get better tissue? You're either going to do a connective tissue graft or a free gingival graft. In a situation like this, I repaired her gum tissue, and then my oral surgeon friend actually had to do the bone augmentation. But the first thing we did was get the gums healthy. So I did a free gingival graft first, and then my surgeon ended up doing a big ridge augmentation, and that's where we started. So we had to put out the fire, got the gum tissue back healthy again, got the bone in place. So we got to utilize our technology, got to get a CAT scan, which is what we're doing here. And we're going to place implants for number 7 and 10. We got a digital wax up going so we can kind of show her a little bit what her teeth are going to look like. So things are going well, and it also enables us, after patients have already gone through a gum graft and then a big bone graft, right? It's nice to be able to utilize this technology because now we can just fabricate a static surgical guide, and we can just drill straight through the tissue because we know exactly where the bone and we know exactly where the implants are going to go. And now we've placed our implants, so we didn't have to flap her open real big or anything like that. She has a little bit of some scarring from her free gingival graft surgery, which I wanted to smooth out, but she didn't want to because this is her smile line. So this is her at about 4 years after restoration at this point. This is her before. This is her after. And so things are looking pretty good for her. And it actually looks a lot like her digital wax up. So she was very, very pleased. Finally, when we talk about immediate implants, this is where technology really helps us out quite a bit. So here we've got tooth number 9. Actually, he has a lot of teeth that need to go, but tooth number 9 is his immediate concern because it's loose. But before we do anything, we always take a CAT scan and we plan everything out really well. So this is our implant that we're going to be placing, utilizing the 3-2 rule. Once again, 3 millimeters. The implant platform is going to be 3 millimeters apical to the free gingival margin. It's going to be 2 millimeters to the lingual, as you can see here. So we want a screw retained restoration if possible. It's not always possible with incisors. So here we are, we're placing the implant. This is just virtual placement here with our CAT scan. There's our diagnostic model that's superimposed over the CBCT. So now it's time for execution. We take out the tooth. Tooth came out relatively easily. We placed our static surgical guide, and then we actually got a template going for a little coping going, for our provisional. And then after the implant's placed, it's placed in the cingulum once again, so we can have a screw retained restoration. And here goes the crown. And then in addition to that, we talked about the importance of grafting the gap. So we're going to graft the gap with our sticky bone. So this is made with, by the way, this is made with the Intraspin. This is also through BioHorizons as well. But we're using our bone graft and our Intraspin, our PRF, to make sticky bone so that we can graft the gap defect around the implant. Here's our restoration in place, and then instead of using a membrane, like a traditional collagen membrane, we are using the PRF membrane, and then here's our final placement here. So this is the CAT scan. So you can see from our execution compared to our plan, we're very, very close, okay? That's why technology is so important for us, because it makes our job easier, and it takes the guesswork out, so we have a lot more peace of mind. So here we are, with the final delivery and healing. And if you're not comfortable with that, sometimes patients might have a deep bite, they might have heavy occlusion, they might be non-compliant. The good news is you can still use a CAT scan, you can still use your lab, but instead of making a provisional restoration, you can make a custom healing cap instead. So that these work really well for molding the tissue and training the tissue the way you want, so you don't have to do it later. It saves you some time, saves you a lot of chair time, saves the patient another surgery. So with that, I've got 5 minutes here to give you some take-home messages. The biggest take-home message here is to begin with the end in mind, okay? Don't just spend your whole day putting out fires. When a patient comes in with a broken tooth or whatever, try to envision and try to set some goals with them so that you're both on the same page as to what they want. You know, maybe aesthetics is their primary concern. Maybe health is their primary concern. Maybe they just want the thing to last a long time or just to chew their food with. But you want to get those goals set. Consider occlusion and force factors in your treatment planning because every case is different. I know we live in a world where we're just constantly saying all on 4 or all on X. Go all on X because some patients may take 4 implants, some may need 6. Everybody's a little bit different. Sometimes you can get away with the narrow diameter implant, sometimes you can't. So you have to really consider the force factors and the patient's parafunctional activity in your treatment plan. That's going to save you a lot of trouble when it comes to loose abutment screws and broken components. Always consider the quantity and the quality of the soft tissue around your implants. If you don't have enough keratinized tissue or attached gingiva, get some. And this is really important for a lot of patients, not every patient, but a lot of patients, because for some people, if they don't have enough keratinized tissue, they get recession around their implants, they get inflammation, plaque buildup, they have a tough time keeping it clean. And not only that, they will suffer some increased crestal bone loss as well. And finally, when it comes to technology, utilize a CBCT. I'm not saying go buy a CBCT, but you got to utilize one. If you have a orthodontist or a periodontist or oral surgeon buddy or something, friend, use their stuff. Or if there's an imaging center in your city, use it. Buy it if you can afford it, but you got to use it because that's what's going to help you with an accurate diagnosis and help you fabricate a treatment plan. But it's also excellent communication, for your patients so that you can show them what you're doing and why you're doing it. So with that, I'm going to close with one of my favorite quotes from Coach John Wooden. It's what you learn after you know it all that counts. So implant dentistry, failed implants, it's all a learning experience. You'll never get to the end of it. It's definitely a journey and not a destination. Keep learning. And the more, if you get nothing out of this webinar, but asking yourself even more questions than what you had, that's great. I've done my job because that's exactly what implant dentistry is all about. A lot of changes in a hurry. So with that, here's my information. Once again, let me know if you all have any questions or concerns, comments. I open and welcome all of it. So thank you so much. I really appreciate you.
Awesome. Well, thank you. You just threw a ton at us. We do have a couple minutes for questions, so I want to get right to them. You say to treat inflammation early. What are your thoughts if the implant is in the early stages of healing after placement? Let's say 2 months after placement and there is inflammation.
2 months is still kind of early. Depends on the situation. So if an implant was placed immediately, you have a healing socket, you might still have some inflammation there. Depending on the trauma that was involved with an implant, you can have some inflammation. Depending on the state of the adjacent teeth, you can have some inflammation. So on those situations, I would say, I'm not saying go treat it at 8 weeks or anything like that, but definitely before the final restoration is placed, you want to get inflammation under control. You got to have healthy tissue. So get to the bottom of it. There's always something going on there. Either plaque, food trap, something is happening in a situation like that. But definitely get it under, I'm not saying 8 weeks or whatever, but definitely get it under control before the final restoration is placed because that's the easiest time.
Do you believe there are certain implant designs or surface treatments that are superior to another when it comes to the failure of resisting peri-implantitis or lack of stability?
Well, historically, the hydroxyapatite surface is the one that's associated the most with rapid breakdown and more rapid and aggressive peri-implantitis, because it's an actual coating, right? Nowadays, most implant companies don't coat their implants; they're etched or treated. So nowadays, there's really not a whole lot of difference from one surface to the next. Most of them are focused on rapidly the implant integrating rapidly. They're not so much focused on preventing disease breakdown. So nowadays it's not an issue, but in the old days you wanted to avoid the hydroxyapatite or the HA coating. Nowadays you don't have to worry about that.
What are some of your go-to instruments for atraumatic extractions?
Atraumatic extractions, super easy. So you got to have to have a set of periotomes. Get a straight periotome and an angled periotome. You got to have it. Can't do anything without it, and they're probably between the two instruments are $150. Go to anywhere. You can go to I believe Henry Schein will have it in their catalog, but anyway, you're looking at two periotomes as a must. Other things that help. I show the piezo surgery unit. There's lots of piezo surgery units on the market. I use the Cube from Action. So that's what I typically use. I believe you can also get that through Henry Schein, but that's nice because it jiggles an implant out basically. And then other things would be, there's another thing called a Benex root extractor. So if you ever break off a tooth and you have nothing but the root left and you don't want to drill it out, look up the Benex root extractor. It's spelled B-E-N-E-X root extractor. But those are the things that I keep in my office all the time.
You explain the tunnel paddle flap for treating peri-implantitis.
Yeah. Oh, explain it. Got it. So sorry. So what a tunnel is you're going to utilize small instruments. You're basically making sulcular incisions and you're going to release the tissue through the sulcus, or a small incision or a hole, distal away from the site that you're actually doing your surgery. Okay. So the idea here is to keep the papilla intact. So you're utilizing sharp instruments to make incisions around the teeth or implants, and then you're using more blunt instruments to peel the tissue tissue and periosteum off of the bone, and to release the papilla without separating the papilla. Okay, so you're not cutting through the papilla. The key point of all tunneling, especially around implants, is to keep those papilla intact, because once you sever the blood supply and peel back the papilla like you would in an envelope flap, you're going to probably get a lot of recession.
How often do you restore the implants versus the referring dentist?
I restore implants very rarely, actually. Most of my dentists do them 99% of the time. I probably do 1% or less, and it's usually special cases. It might be a family member or somebody in the dental community that wants me to do it.
Do you always utilize PRF with allograft to graft the gap in immediate placement?
I do now. Before 3 years ago, I did not. I used a regular membrane, but now I do, just because the PRF, if you look at interest spend, I think it's something in the neighborhood of $4 to $6 to do it for the patient, including the disposables and everything. So it's very inexpensive to do.
Had a clarification from the very first case you shared of the peri-implantitis. Was the standard treatment the tetracycline plus sterile water plus MTA for 4 minutes?
Okay, so there's no MTA. It's what it is. It's just tetras. So you clean it first, scalar, rotary, whatever you want to do. Clean the implant off, and then what you do is you open up a capsule of tetracycline. You put it in some sterile water, and you just mix it together into a nice little paste. Dip your cotton pellets in it, and then you use the cotton pellets to burnish the implant surface for about 4 minutes. But that's it. There's nothing else but the tetracycline.
How well does Alloderm work for you?
Alloderm and all of the derms work excellent in my hands. Yeah, very predictable. I'd say it's a rare that I've ever had a failure.
And last question: can oral surgeons do FGG?
Ben Johnson probably wrote that in, I bet. But
yes.
You know what? Ben's pretty good at it. I like to give him hell about it, but I believe that all surgeons, should be utilizing FGGs. Very, very predictable, very simple to do. Once you get the hang of it, it's like riding a bike. I mean, once you do the first one, and it takes, it's easy. And it's very, very simple to do. Right up a surgeon's alley.
Cool. All right. Well, that's all the time we have. So thank you, Dr. Wong, for your awesome presentation today. And thank you, everyone, for attending. As a thanks for attending, we will be sending out a link of today's webinar in the coming week via email. So look out for that. On behalf of Henry Schein, thanks again to Dr. Wong, and everyone have a great rest of the day.
Thank you, guys. Appreciate you.